doing it on my phone. Okay, 1 minute.
Hi, Shashmita, how are you?
Hello, good afternoon, sir. I am fine. Yes, sir. Sir, I have to speak on module 2, safe
Yes.
abortion tools. Yes.
We're just waiting for another 2-3 minutes. We can start. Actually, we have about 37 registrations today. I can only see 12 are online. I don't know.
Good afternoon. I'm from Thane.
Good afternoon. Good afternoon.
So,
So
can
many
you see now?
societies?
Yeah, we can see single slides now.
Okay, they're moving, right?
Yeah.
Yeah.
Okay, thank you.
Sir, Dhira training we have taken, but the certificate is not coming.
No, but there are no certificates which are pending, actually.
Post assessment, I have also submitted.
Yeah.
Even I haven't got it, Ajay.
I'm really surprised because maybe Srivan can help out. All certificates, there are no certificates which are pending.
I'll resend the certificates, ma'am, again then, because we already sent the certificates to everyone.
Yeah, because many times what it is happening, it is coming from an unknown email in your, email account, because that email is coming first time. So maybe many a times it is going into spam folder. So you have to just check in the spam folder also. But in the meantime, what we'll do is we'll just, Sriman, if you can help with Uma and Sashmita, both of the certificates. We'll email them to you again.
Yes, sir. Yes, sir.
Good evening, sir.
Hi, good evening, Emma. How are you?
Yes, sir. Fine, sir.
Shall we start, please? For another minute, 4:05. You can. Uma, are you set?
Yeah, I'm done, Dr. Ajay.
So we have about 18 of us here right now.
So, any more have to join?
Today, total registration is about 37. And we have 18 of us right now. So I guess people may join in or must be joining in. We can start the session.
44 registrations, sir, till now.
Sorry?
44 registrations, sir.
44 registration. Okay.
Sir.
I checked earlier. It was 37. So 44 registrations are there. So I guess we will.
17.
Guess we will just start now because it's. We want to end up. I have another meeting at 6:30. So. Yeah. So good evening and good afternoon, everyone. Thank you very much for joining in today's important session on respectful abortion care, which is the flagship program of our president, Dr. Shanta Kumari, in collaboration with WHO, India Office, and Government of India, Ministry of Health and Family Welfare. The entire program is for about 2 hours today. And during this program, we will be covering 4 topics. The first topic is going to be related to the medical termination of pregnancy 2021, the amendments which have come about, and how these amendments have to be navigated and to be, used by all of you all in terms of your better understanding of what is happening. The second topic is on safe abortion techniques. This is another topic which Africa will be taking. It really is not absolutely new. It's all of it. You are all doing it in your day-to-day practices. However, it's a reiteration of all that you have been doing in a more systematic and a more formal way here, so that all of us are on the same page. The third one is an important module called the SAVOR module. It's an acronym. And the full form, colleague, Prema Priya will be talking about that, which essentially is a WHO tool in order to understand and take care of your patients and accord the respectful abortion care that we are talking about. The last topic is of pre-counseling and post-counseling, which is another factor, an important one to be addressed, and how and what one needs to be doing all such cases in order to accord and give a complete respectful abortion to the woman desirous of taking this forward. In terms of the MTP itself, I think India has been a unique country because it's almost 50 years now. And when we began the entire program almost 50 years back, it was known as the unsafe abortion. And we have come a long way and now talking about respectful abortion care. India perhaps is the only country which has something like this going on continuously in terms of its evolution. And many countries even today are struggling to get their MTP's laws in place. So I think huge congratulations to our country, our countrymen, and the lawmakers who have made this possible for all of us, and several partners who have been working with the Ministry of Health and FOXI to make this possible. So on that note, I will request our first speaker for the day, Uma, who will be walking us through the MTP amendments. And Uma along with Sasmita and with Prema Priya are master trainers who have been trained by FOXI WHO and have been successfully conducting similar programs across the country. And so far, we have trained about 8,000 fellow FOXians in this entire program, and going strong and carrying the entire MTP Act forward for each other. On that note, thank you very much for a patient hearing, and let's jump into the entire program. Uma, over to you.
Yeah, thank you. Thank you, Mr. Ajay. So straight getting into the first module.
My video can't be gotten off because it's 1 minute. Okay, hopefully now it should go off. Yeah.
Okay, so getting straight into the module, this RAC training program is jointly organized by FOXI and WHO. And we will be discussing in the next 20 minutes or so, talking about the changes that have been made in the MTP Amendment Act. And we would compare it with the previous act so that we will understand what the new rules of termination of pregnancy are and what are the changes made and what are the implications of these changes. This is a way to provide formal information about MTP Amendment Act 2021. So I will try to keep it as simple as possible for the next 20 minutes or so. And any questions, please post it on the chat box. Now, getting straight into the MTP Amendment Act. First, what was the need to change and bring the new law for this MTP Amendment Act. There was a need for change in the MTP Amendment Act because unsafe abortions are identified to be as a leading cause of maternal mortality, and 8% of maternal deaths in India are due to abortions. And also, the most worrying fact is that nearly 2/3 of abortions are performed by, which are performed or deemed to be unsafe, and also nearly half of the pregnancy-related deaths are in women and girls under 24 years of age, and that's really heartening. So when do we consider abortion as safe? Abortion is considered safe, when it is done by appropriate recognized method and by an appropriate trained person. So abortion should be considered safe, or we should consider it as a safe abortion when both the criteria are met by trained person and by appropriate method. So this is the new MTP Amendment 2021 Act, which has been mandated by law in March 2021, and rules have been framed and is in the form of a gazette on 25th of September 2021. Now, straight getting into the salient features of the MTP Amendment 2021. In the previous act, there is a requirement of opinion of one provider for termination of pregnancy up to 12 weeks. And if it is beyond 12 weeks and up to 20 weeks, there was required to take opinion of 2 registered medical practitioners for MTP. What is the modification in the current MTP Act? Requirement for opinion of 1 registered medical practitioner for termination of pregnancy up to 20 weeks of gestation, and requirement of opinion of 2 registered medical practitioners for termination of pregnancy from 20 to 24 weeks of gestation. So gestational age also has been increased, and also the requirement of opinion of registered medical practitioners is also modified. What is the likely potential benefit or advantage we get from this is the increase in number of facilities, especially in public sector like health centers, might become eligible, because most of the health centers will have only 1 registered practitioner. So they might get eligibility to do a termination of pregnancy up to 20 weeks of gestation, and thereby increasing safe abortion rate. The next salient feature in the MTP Amendment Act is that MTP is permissible beyond 20 weeks of gestation only when, this was in the previous act. We all know that MTP is permissible beyond 20 weeks only when it is immediately necessary to save the life of the pregnant woman. Otherwise, even if the baby had anomalies, we were not able to do termination of pregnancy. Now, with the current amendment, they enhanced the upper gestation limit from 20 to 24 weeks for special or vulnerable categories of women. I'll come to that point. Who are the special and vulnerable categories of women? But you should note that there is an enhanced gestational limit from 20 to 24 weeks.
Sorry to button like this. On the screen, we are seeing this small icon, which is you have to navigate, and we're not able to see the full slide. What I'll request is, Sriman, if you can share the slides.
Yes, sir, I'll do so.
And Uma, is it okay? Then you can keep saying next. So then
okay.
Navigate it for you.
Yeah, that should be good.
Yeah, because this is, you have to play around with a little bit. So
yeah, I'm stopping
because using your mobile, that's maybe we are not figured out how to do it on the mobile. Okay, thank you, Sriman. You can share it. Yeah.
Yes, Sriman.
My screen is visible, ma'am.
Yeah, can you go to the move on. Okay.
Is the same slide, ma'am, or should I move on, ma'am?
You're sharing MTP. Yeah, it's the same slide. Thank you. Thank you, Sriman.
Welcome, ma'am.
So in the previous act, MTP is permissible beyond 20 weeks only if it was life-threatening to the pregnant mother. But now with the current changes, enhance the upper limit of upper gestational limit from 20 to 24 weeks for special or vulnerable categories of women. And there is also further enhancement of gestational age. I mean, for birth defects which are not compatible with life. You know, you have to really look into this aspect. Birth defects not compatible with life on medical board consensus. So what is the potential benefit or advantage of this is the increase in access for vulnerable women to safe and legal abortion services. And these special and vulnerable groups are defined, and I will come to that later. Next slide. The third salient feature is the modification of, in the previous act, they had a provision for provision of termination of pregnancies only up to 20 weeks. Now, the upper gestational limit does not apply in cases of pregnancies with substantial fetal anomalies diagnosed by a medical board. So, the new current modification does not give any upper limit of gestational age for termination of pregnancy. But if woman is more than 24 weeks of gestation and fetus has substantial fetal anomaly or a lethal fetal anomaly diagnosed late, then you have to seek an opinion from the medical board, get a permission for termination of pregnancy. What is the potential outcome is increase in access to safe and legal abortion services again. So everything is narrowed down on to improving the safety of abortion, safety in the process of abortion whenever woman seeks or, woman seeks abortion. The next. So a modification status. In the previous act, the condition of failure of contraception was applicable for only a married woman or her husband. Now, with the current amendment, a condition of failure of contraception is extended for any woman or her partner. Irrespective of the marital status. Especially with the changing socio-cultural profile, this change is deemed necessary, and failure of contraception for a unmarried woman is accepted as a clause for termination of pregnancy. Next. Finally, there was a new clause for strengthening privacy, so that any woman who can have respectful abortion care whenever she is seeking MTP. Information should not be disclosed. New amendment, name and other particulars of a woman whose pregnancy has been terminated shall not be revealed except to a person authorized by any law or for the time being in force. So this is all to ensure the privacy of the woman, ensure confidentiality of the woman, whoever is seeking termination of pregnancy, so that, patient will come for a safer, services, safer abortion services will be accessed by the patient. Next. So, so these are the salient features in the amendment in the new law. Any law comes with a set of rules to be followed. So, what are the rules under MTP Amendment 2021? So, till now we have been talking about the upper limit of gestation being enhanced from 20 to 24 weeks, the requirement of registered medical practitioners, and few clauses that have been placed. But what are the new rules? How do they define a vulnerable group? Is what is framed in the law. Next. Next, Sriram. Okay. So rules that guide us through this MTP Amendment Act define special or vulnerable categories of women who are eligible for extended gestational period for termination of pregnancy from 20 to 24 weeks. The norms of the registered medical practitioner whose opinion is required for termination of pregnancy at different gestational ages is very specific and is well defined. the powers and functions of the medical board, whoever constitutes the medical board, OB/GYN, radiologist, or fetal medicine specialist, is formed for each state and mandated to provide timely evidence-based decisions. So what are the powers and functions of medical board are all defined in these new rules for termination of pregnancy. Next. So who are the special or vulnerable category of women eligible for MTP? Next, Sriram. So who are the vulnerable or special group of women eligible for termination of pregnancy between 20 to 24 weeks? So I'm repeating this again. There is an enhanced gestational age limit from 20 to 24 weeks. It's not a blanket enhancement. It's only for women who fall under this special category of women. So now these are the 7 groups of women as defined by law, and they are women with physical disabilities, major disability as defined by the Disability Act.
Madam, we can't hear you. Madam, we can't hear you.
Can you hear me now? Yeah. There are women with physical disabilities, major disability as per the criteria under the Disability Act, mentally ill women, including mental retardation. If a patient is a minor, change in marital status during the ongoing pregnancy, she could be a divorced or a widowed woman. Women with pregnancy or in humanitarian settings, disaster, and or emergency situations which are declared by Government of India. You can't decide. Survivors of sexual assault, rape, or incest, and if there is a fetal malformation that has substantial risk of women that is incompatible with life, or a child would be born with a serious mental or physical disability. Remember, still the old rule of upper limit of 20 weeks apply. Beyond 20 weeks, it is not a blanket change. 20 to 24 weeks is only for this particular group of women. These are defined as vulnerable group of women by Government of India, and you should strictly adhere to these rules and see if your patient will fit into these criteria. Next slide, please. And if there is a patient with a fetal anomaly, there is no upper limit of gestational age for MTP if there is a substantial fetal anomaly. But again, you should, termination of pregnancy beyond 24 weeks is subject to medical board opinion. Now, what is the second rule? Registered medical practitioner is defined in the old Act as MBBS or more with any of the following. Medical practitioner who has been assisting MTPs or assisted in 25 cases of MTP, of which at least 5 are done independently in a hospital. A medical practitioner who has completed 6 months of house surgency in obstetrics and gynecology. A medical practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology, or a practitioner who has experience of at least 1 year of practice in obstetrics and gynecology. Now, one such RMP opinion is enough up to 20 weeks. 2 registered medical practitioner opinion is needed from 20 to 24 weeks. And if there is a need for termination of pregnancy beyond 24 weeks, you should take an opinion of the medical board. Next. Next, Sriman. So what are the norms? Now with the new Act, one registered under the new rules for termination of pregnancy up to 9 weeks with medical method, only additional category provided has been added. This provided includes a registered medical practitioner with experience in practice of obstetrics and gynecology at any hospital for 3 months. So this is a new only up to 9 weeks and with medical method. Training with performance of 10 cases of MTP only with medical method under supervision of a registered medical practitioner in a hospital established or maintained or a training institute approved for this purpose by the government. So this is only for medical method under 9 weeks of gestation. An RMP with an experience in medical management for 10 cases. Next. Next. Shrima, next slide.
I will change the slide, madam.
Okay. So the norms for registered medical practitioner whose opinion is required for termination of pregnancy at different gestational ages is well defined. Till 9 weeks, experience and training requirement for medical practitioner include an experience at a hospital or 3 months in a practice of obstetrics and gynecology, or has independently performed 10 cases of MTP by medical method under supervision of an RMP, or a registered medical practitioner who has assisted a performance of 25 cases of MTP, of which at least 5 have been done independently in a hospital. A practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology, or can be a practitioner who has completed 6 months of senior house surgery in obstetrics and gynecology, or a practitioner who has an experience at a hospital for a period of not less than 1 year in the practice of obstetrics and gynecology. So this category 1 is additionally added category, so that it's below 9 weeks and it's only for medical management. Next. And from 9 weeks to 12 weeks, so what is the experience and training requirement for registered medical practitioner? A practitioner who has assisted a registered medical in a performance of 25 cases of MTP, of which at least 5 have been done independently in a hospital. A practitioner who has postgraduate degree or diploma in obstetrics and gynecology. A practitioner who has completed 6 months of house surgery in obstetrics and gynecology, or a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of obstetrics and gynecology. So opinion of one registered medical practitioner is enough, as it is within less than 12 weeks. Next. So beyond 12 weeks until 20 weeks, what is the experience and training requirement for registered medical practitioner? So a practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology, a practitioner who has completed 6 months of house surgery in obstetrics and gynecology, or a practitioner who has an experience at a hospital for a period of less than 1 year in the practice of obstetrics and gynecology. So only these 3 category of physicians or registered medical practitioners are eligible to perform MTP beyond 20 weeks and beyond 12 weeks and until 20 weeks. An opinion of one registered medical practitioner is enough as per the new law. Next. So what's the necessity or the requirement of experience and training beyond 20 weeks and until 24 weeks? A postgraduate who holds a registered medical practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology, or a practitioner who has completed 6 months of house surgery in obstetrics and gynecology, or a practitioner who has had an experience at a hospital for a period of not less than 1 year in the practice of obstetrics and gynecology. Now, beyond 20 weeks and until 24 weeks, you have to get an opinion of 2 registered medical practitioners before you terminate the pregnancy. Next. Beyond 24 weeks, now comes the experience and requirements are that a registered medical practitioner with a postgraduate degree or diploma in obstetrics and gynecology, or a person who has been working in the hospital for a period of not less than 1 year in the practice of obstetrics and gynecology. Here, the termination of pregnancy beyond 24 weeks is only if there is a substantial fetal anomaly. Now, after 24 weeks, an opinion of medical board is required for termination procedure. When advised by the medical board, is carried out with all safety precautions along with appropriate counseling and appropriate medical management aspects. Next. So what is a medical board? Now, many times I have been discussing about medical board. So, what is a medical board? Who constitutes the medical board? It is a new term, and medical boards are newly formed in most of the states or districts in our country. So, what is the composition of medical board? A composition of medical board constitutes of a gynecologist, a pediatrician, a radiologist, or a zoologist. A board will have one chairperson who will be possibly a department head or a superintendent. Next slide. Medical board is formed by concerned government authorities, say like DMHO or at a district level or at the state government. Because health is a state chapter, medical boards have to be formed within your states, by the district health authorities or state government, whosoever is concerned. And also, what are the powers of the medical board? Medical board has right to allow or deny termination of pregnancy beyond 24 weeks of gestation. And they have, before they take the decision of allowing or denying, they have to review the whole scenario, also consider, if they need to take opinion, they can take opinion from other specialists, like say if they want opinion from a pediatric cardiologist, if the baby has fetal anomaly, they can always go up from get an opinion from other specialists like fetal medicine specialist or a pediatric urologist or a cardiologist or whatever. They should look into and whether the fetal malformation has a substantial risk of it being incompatible with life, or if the child when born will suffer from severe physical or mental abnormalities or could be seriously handicapped. Only in these situations, medical board, would allow for termination of pregnancy. Whenever needed, medical board will involve other specialists, as I have mentioned, before they take decision on termination of pregnancy. Next. So what are the functions of medical board? To examine the woman and her reports who would approach her for medical termination of pregnancy. Opinion of medical board has to be provided in a form called Form D with regard to termination of pregnancy or rejection of request. Whatever is their opinion, they have to provide in a form called Form D. And that form has to be, their opinion has to be provided within 3 days of receiving such request for termination of pregnancy. Medical board also has to ensure that termination of pregnancy is carried out with all safety precautions and counseling within 5 days of receipt of request for termination of pregnancy. So they have to give opinion within 3 days of a request and have to ensure the termination is appropriate termination counseling has been done within 5 days of receipt of request for termination of pregnancy. So here you have to remember that FOXI has an important role to play in ensuring these are functional medical bodies in every state, and as I stated in the MTP Amendment Act. So I think FOXI is working to ensure that medical boards are formed in each and every state and every district, in fact, so that patients can go and access the medical board to seek permission for termination of pregnancy. Next. So whenever you see a patient with with a substantial fetal anomaly, you just have to write a letter to the medical board on a plain white paper, and they will give an opinion whether this patient is eligible for termination or they don't want, or they refuse it, whatever. So in India, to sum up, abortion is legal. We have to follow the rules and regulations which are specified by the law, and we all can work to make abortion safe and respectful. Thank you.
So should I start my topic?
Shriman?
Yes, madam.
Yeah, can she start a topic, please?
Yes, madam.
Yeah, I have finished mine, ma'am. You can, please.
Should we start my topic?
Yes, madam.
Yeah. Okay, I'm starting. So good afternoon, everybody. I am Dr. Sasmita Swain, Secretary AOGO from Odisha. Today I'll be speaking on Module 2, that is safe abortion and updates in technology. So this is a joint venture of FOXI and WHO. I am thankful for the organizer for giving me this opportunity to be the part of this flag bearer project of FOXI. So in this session, we will see the existing guidelines, then pre-abortion assessment, medical methods of abortion available, and the surgical methods of abortion. So all these are only recapitulation and to do in a respectful manner. So this is the WHO Global Guidelines on Safe Abortion. These are the books available from WHO. Anybody who wants can follow this. These are also the roadmap of WHO for safe abortion guidelines from 2012. They have come to 2019 with all these books. So the Ministry of Health and Family Welfare National Guidelines on Self-Abortion, that is a historic change in 2021 as just discussed by Dr. Uma, the Medical Termination Pregnancy Amendment 2021. These rules changed on 24th September 2021. So all these guidelines, what is the aim of all these guidelines? These guidelines have only single aim is to perform the abortion safely. The only aim is that we should have the abortion safely so that no complications should arise from it. For this, we have to look for the three key areas. What are these? The pre-abortion care. Before conducting the abortion, we must assess as the person as a whole. Then the abortion care methods. What are the abortion methods available and which is safest for the woman? That we have to look. Then aftercare and follow-up. This is also very, very important. We have to take aftercare and follow up the case. And we should also advise regarding the post-abortion contraception and counseling should be done. And in all these things, the woman should participate in making the decision which method should adopt, which contraception should adopt. She has to be a part of this decision making. So coming to pre-abortion assessment and counseling. So in pre-assessment assessment, we have for women seeking first trimester abortion. So we have to look the woman as a whole, not that only she has come for abortion. So we must take a detailed history. In history, from history, we can avoid many complications which may arise from the procedure. So in history, we should take history of asthma, any history of heart disease, or any history of drug allergy, or any history of blood transfusion. All those things we should take. And also in history, we should take the last menstrual period history very correctly. That will give what method we have to apply. We have to proceed. And we also do a general physical and pelvic examination. So when the patient is coming to us for the first time, we should do a general examination. Specifically, you must see the degree of pallor. What is the degree of pallor present? whether she is suffering from any cardiac disease, whether she is having any asthma, that things we must do a systematic examination also. And along with that, we must do a para-abdominal examination to know the height of the uterus. And also, if it is not palpable para-abdominally, we must do a pelvic examination to see what is the corresponding gestational age and whether it is a uterine or extra-uterine pregnancy. So for that also, it is very important. And we have to go for laboratory and other investigations when it is required. And after that, we have to counsel the woman, inform the woman regarding the MTP, and also make her part of decision making. So coming to the gestational age determination by LMP or by physical examination, we all know at 12 weeks, the uterus becomes a pelvic organ. Around umbilicus, it becomes 24 weeks. So between this, we have to perform the MTP. So what are the limitations of dating by uterine size only? Sometimes if we do see the LMP and before examining the patient, we should calculate the gestational age before examining. So when we examine, we must see whether the gestational age is corresponding to the period of amenorrhea or not. If it is less than the period of amenorrhea, then maybe we have to double check whether she is saying the LMP correctly or not. If she is sure of her last menstrual period, then we must see whether it is maybe a missed abortion, maybe wrong date, or it may be a ectopic pregnancy. That is very, very important. Before going for any MTP procedure, you must exclude it is an extra-uterine pregnancy. Sometimes the height may be more than the period of amenorrhea. In those cases, again, we have to see whether it is a wrong LMP or she is not telling correctly, or it may be a multifetal pregnancy, or it may be associated with fibroid, or it may be a molar pregnancy. So in all those cases, we have to go for other investigation and make sure what is the exact gestational age. That is also very important. So what are the investigations? So as per the recent guidelines, routine lab test is not a prerequisite for abortion services. So routinely, which is not required, but tests that may be performed as per individual risk factors on finding of physical examination. If pregnancy are not, if the obese patient is or not cooperative to do the PV examination, you are not sure whether she is pregnant or not, because sometimes the uterus may be small. There may be a period of amenorrhea, but patient may not be pregnant at all. This happens many times. And if you go for a surgical procedure, may land with perforation. So whenever required, we can go for a pregnancy test if pregnancy is not confirmed. Then hemoglobin, if you suspect the patient is anemic, we may have to go for hemoglobin test. And if the RS grouping of the patient is not known, then we have to go for RS typing, because if the woman is RS negative, even in first trimester, we may have to give her anti-D. And sexually transmitted infection screening, it is usually performed during the pelvic examination by seeing the or any other laboratory test as indicated by medical history. If there is any chronic kidney disease or jaundice is present, in those cases, we have to give the test. Otherwise, routine investigation is not a prerequisite. Ultrasound is not necessary unless to diagnose pregnancy not certain of suspecting ectopic or missed abortion. If you suspect an ectopic pregnancy, or if you suspect a missed abortion because the height of uterus is less than the period of amenorrhea, then for confirmation, we can advise the ultrasound. So, again, during this pre-abortion counseling, we have to counsel the patient. We have to ask why she is going for termination, and we have to inform that early abortion is always safe, and it is important to have a trained provider performing the procedure for safety. That's why the amendment has become very lenient. Guardian, except the parents, may be allowed for this also to be present. And what are the available methods of abortion that we have to tell her? Risk and warning signs associated with the abortion method, that also we have to inform. And we have to tell her that after abortion, if she goes without any contraception, then after 14 days, she may become again pregnant. So she has to adopt some contraception. That counseling we should do before abortion. And she can resume her normal activities, including the sexual intercourse, after the MTP Act. If she is suffering from any other disease, any other follow-up if required, we have to counsel or inform her. And most important is the documentation. Even if in first semester we have to take informed written consent of the patient, and we also have to document the decision to accept post MTP contraception. Even if she is not willing for contraception, she will be provided of the abortion services available. That is also very important. We must give the importance to the contraception. So there she will be counseled, she will be explain what is the advantage of contraception, because by giving some contraception, we can avoid many complications. So contraception factor should be given the importance during the abortion and pre-abortion also. So coming to the clinical management of abortion. Abortion should be less than 12 weeks or more than 12 weeks. Less than 12 weeks, the global recommendation is mifepristone and misoprostol, or misoprostol only, or vacuum aspiration. For this, the Government of India recommendation is medical method of abortion up to 9 weeks. This is only up to 9 weeks. The 9 weeks they have divided into 2 parts. Up to 7 weeks, that is 49 days. Of 7 to 9 weeks, up to 49 to 63 days. The dose is same almost. Up to 7 weeks, we have to give mifepristone 200 milligram oral, wait for 24 to 48 hours. Then we have to give misoprostol 800 microgram, either sublingual or buccal or vaginal or oral. 4 routes of misoprostol can be given. In 49 to 63 days, that up to 9 weeks, you have to give mifepristone 200 milligram orally, wait for 24 to 48 hours, then give misoprostol 800 microgram sublingual, buccal or vaginal. Oral is not advocated in case it is more than 7 weeks. So up to 7 to 9 weeks, the mifepristone and misoprostol should be given, and misoprostol is given only by 3 routes: sublingual, buccal or vaginal. Beyond 12 weeks, the global recommendation is mifepristone and misoprostol, or misoprostol only, or dilatation and evacuation. So this is the methods of first semester abortion, medical method of abortion, or surgical method of abortion by MBA or EBA. So this is just a repetition. What is mifepristone? Mifepristone is an anti-progesterone which inhibits the action of progesterone, which is the hormone of pregnancy. So when the progesterone is inhibited, it interferes with continuation of pregnancy. So once pregnancy is interfered, then we give misoprostol. Misoprostol is a prostaglandin E1 analog. What is its action? It causes cervical softening and uterine contraction and helps in expulsion of the product of conception. So first give mifepristone, then followed by that we have to give misoprostol. So this is again the repetition, the protocol of mifepristone and misoprostol. Day 1, mifepristone administration, 200 milligram mifepristone oral. If she is RH negative, we have to give anti-D 50 microgram IM if she is RH negative in the first day. And on the day 3, this is misoprostol. In day 3, up to 7 weeks, 400 microgram of misoprostol, 2 tablets, sublingual, buccal, vaginal or oral, or 7 to 9 weeks, 800 milligram sublingual, buccal or vaginal. In addition to this 7 to 9 weeks, patient may have some pain. So because we have to be we have to give quality cervix. So patients should not have excessive pain and she should be relaxed. For that, we have to give some analgesic like ibuprofen, because this anti-progesterone, misoprostol may have some gastritis or dizziness, nausea. For that, we can advise also some anti-emetic. Along with that, we have to offer some contraception. So next, we can ask them to come after 15 days for follow-up, and after 15 days when she comes, we have to confirm whether the completion procedure, the procedure is complete or not. This we can do by a PEBB examination and from history also. And we have to offer contraception if not already done. So what are this is the drug they have described. Characteristics of different routes of misoprostol administration for first trimester abortion. Misoprostol oral pills are shallowed. The side effects are more side effects in this oral. It is recommended up to 7 weeks. Buccal pills are placed between the gums and the cheek and swallowed after 30 minutes. Sublingual, this is the fastest onset of action is the sublingual. Just remember, fastest onset of action is along the sublingual variety, if you sublingual route. So in this, with the tablet has to be placed under the tongue and it can be swallowed after 30 minutes. The vaginal route has the least side effects. So the pills can be placed in the vaginal furnaces, deepest portion of the vagina, and the woman is instructed to lie down for 30 minutes. So sublingual is the fastest onset of action within 2 to 3 hours, and the vaginal has the lowest rates of side effects. So this is the buccal variety between the cheek and the gum. This is buccal. This is sublingually just under the tongue. So the WHO recommendation dose schedule of medical abortion is less than 12 weeks, 200 milligram of mifepristone orally, and 800 microgram of misoprostol, buccal or vaginal or sublingual. Vaginal bleeding for 2 weeks is normal after medical abortion. So we need not worry if there occurs bleeding PV, which is not very high, very heavy. But 2 weeks, it may be normal. Such bleeding can last up to 45 days in rare cases. So we should not worry if there occurs continuous little bleeding for 2 weeks. So where should the medical method of abortion should be available? So these services should be available at the primary care level. And along with that, we have to counsel and test for sexually transmitted infections. We have to give them psychological support. And if they require any specialist health or medical services, we have to also counsel for that. And we have to provide iron if the patient is anemic. Along with this abortion MMA, we have to provide them iron if they are anemic and provide necessary pain medications. And very important, we have to provide emotional support. We do not know under which circumstance they have come for MTP. So we have to give them emotional support so that they should not be disheartened and they should not be afraid to come forward to have abortion. Because when they go back, they will tell their story to the others and that will spread, and nobody who wants MTP will not come to us, because our aim is to have the safe and respectful abortion care. So if we provide good care to the person, that person will go to the community and spread that it is they are not abused or they are not tortured in the hospital or by the healthcare persons, so that they will not feel afraid to come to us. That is the main of this, the aim of this amendment. They should come to the hospital healthcare persons. So how to follow up? Routine follow-up is not necessary following an uncomplicated medical abortion using mifepristone and misoprostol. A follow-up visit 7 to 14 days after the procedure may be offered to provide contraceptive counseling and services, emotional support, and address any medical concerns. So if you want to call for follow-up, during this follow-up, you have to counsel for contraception, you have to give them emotional support, and we have to address any other medical disease if they are suffering. A routine follow-up visit is recommended only in case of medical abortion using misoprostol alone to assess, because if you use misoprostol alone, the chance of incomplete abortion is little high. So if you are giving misoprostol alone, you have to come for follow-up to assess the success of abortion. So it is always preferable to use combined method. So in the follow-up care, assess woman's recovery and ask for any signs or symptoms of ongoing pregnancy, because this is also very important. Even if it's very small, but there is little chance of failure. So in the follow-up, you must ask and look for any signs and symptoms if that pregnancy may be continuing. That you have to exclude. And we have to review any medical record, ask about, and we have also a physical examination. And assess woman's fertility goals, what she wants, whether how long she does not want to get pregnant. For that period, we have to give, whether we have to give copper T for a prolonged, if she wants a long gap, then we can ask her to take copper T, or if she wants for a short period, we can provide her OC pills. So we have to counsel regarding the contraception. So coming to the summary of the medical method of abortion, day 1, what to do? Do physical and pelvic examination. And I will add, before that, you take a proper history. In physical examination, exclude or assess the degree of anemia, exclude any heart disease, exclude any respiratory disease also. Then confirm the eligibility to which groups he belongs, whether it is up to 7 weeks or it is 7 to 9 weeks or beyond 9 weeks. So that you have to confirm the eligibility to which criteria he belongs. So then you give mifepristone 200 milligram orally, and if she is RS negative, give anti-D. So, and tell the woman to return for misoprostol administration after 2 days, and you have to keep the contact address and phone number of the the patient has to keep the phone number of the facility where she has come, and we should also keep the number for follow-up also. And we have to give her the MMA card. On the second visit, that is day 3, we have to give misoprostol 400 micrograms sublingual, buccal, vaginal or oral if it is within 7 weeks, and observe for 4 hours. You have to give analgesia and contraception. Tell the woman the mean period of bleeding may be 8 to 13 days. Possible side effects like nausea, vomiting, diarrhea. If you counsel that these minor things can happen, the acceptance rate of this will be better. So we have to report that you may have little degree of nausea, vomiting and all those things. And she has to report if there is excessive bleeding, excessive pain or fever. Because excessive bleeding may be, the patient may go into shock, pain, abdomen severe, maybe we have missed ectopic pregnancy. That is very, very important. And report if there is bleeding, no bleeding, because if there is no bleeding after 24 hours of misoprostol, consider giving misoprostol or double check your diagnosis. On third visit, what to do? Pelvic examination to ensure that completion or continuation of pregnancy. That is very important. And we have to give contraception like hormonal methods, condoms, IUCD or sterilization after 1 menstrual cycle. Tell the woman about immediate return to fertility. That we have to tell that she may again retain fertility and she may again become pregnant immediately if she does not adopt some contraception. That we have to tell her repeatedly. She should adopt some form of contraception. And ultrasound is indicated if you are not sure it is complete or not. So we have to be respectful. We have to be non-judgmental. That is very, very important. We have to be respectful. We have to be non-judgmental. Why she has done, why she is doing that, we cannot tell. She has come, we have to do it. We have to do it qualitatively so that she should not have any pain or any side effects, and it should be not a bad experience for the pregnant woman. Adequate counseling is very important. Support, ibuprofen has to be given. What will happen if there is failure? That is also very important. So if there is failure, you have to go offer vacuum aspiration, or we can repeat the procedure of medical method of abortion again if it is failure. If it is incomplete, what to do? If it is incomplete, if there is no heavy bleeding, we can observe. If the bleeding resolves, it becomes normal size, then the abortion is complete. But if the bleeding does not come down, we can repeat misoprostol again, 800 microgram. If the heavy bleeding still continues, we have to go for surgical evacuation. So if there is excessive bleeding, woman presents with excessive bleeding per vagina, bleeding more than her menstrual cycle, soaking 2 pads in 1 hour for 2 consecutive hours, bleeding decreases over time, then routinely we can observe, go home. If it is not coming, watch for vital signs. Do the PV examination and see if you can feel product of conception in the cervical canal. If it is there, then we have to go for digital evacuation. If with digital evacuation, woman is stable, bleeding stops, then we can discharge her. If after digital evacuation also, the bleeding continues, then we have to do the ultrasound and see what is the product of conception. If it is minimal decidual bits, we can wait. If it is product of conception and decidual bits, woman is stable, we can give misoprostol again. But it's not stable, we can go for vacuum aspiration. If it is a continuation pregnancy, then go for vacuum aspiration. So this is the algorithm to how to manage if the patient comes with excessive bleeding. So if the patient is stable, we can observe. If there is still bleeding is more, we can do a PB. If the POC is felt, we can digitally remove it. If bleeding decreases, we can leave her. But if after the removal of this, if bleeding continue, we can go for ultrasound. If it is product is there, then we have to go for surgical. Or you can repeat also misoprostol. Very important is the recording and reporting. Since remember MMA or medical method of abortion comes under the purview of MTP Act, documentation is similar to that required for a vacuum aspiration procedure. So it is mandatory to fill the following forms. What are they? Form C, that is the consent form. Form 1, the RMP opinion. Form 2, monthly reporting form. This has to send to the district authorities. And Form 3, that is admission register for case records. So we have to fill up these cases even if it is a medical method of abortion. We have to report to the district. So next comes the medical first trimester abortion of surgical methods, that is MBA or UVA. So surgical method of abortion in the first trimester is beyond 9 to 12 weeks, we can go for surgical abortion. The WHO recommends manual vacuum aspiration as a safest method. The procedure should not be routinely, we should not go for such curettes. So we all know what is this vacuum aspiration method. It is the IPAS method. In this, we have to use 8 mm cannula for 8 weeks gestation and 10 mm cannula for 10 weeks. So this is the assembled MBA aspirator. This you can use. This is the cannula. According to the gestational age, you have to corresponding cannula has to be used. This is the vacuum machine. So before going for MBA, we have to make the cervix priming or ripe. What is a ripe cervix? Ripe cervix should be very soft and easily dilatable. So how will make the cervix ripe? So for that, we can, recommendation is that for cervical ripening, we can use oral mifepristone 200 milligram 24 to 48 hours in advance, or practically we are all are using misoprostol 400 milligram, that is 2 tablets, sublingually 2 to 3 hours prior to the procedure. So ideally, if you are going for MBA or success in evacuation, you advise the patient to put 2 misoprostol 200 microgram tablets below the tongue and swallow it after 30 minutes, so that this will make the cervix very soft and easily dilatable, and this will prevent many complications. Most important is the perforation. If you forcefully dilate the cervix, there is chance that you may cause perforation of the uterus. So to avoid this wonderful drug misoprostol is easily available. This we can use in all cases. If you are going to give vaginally, then you have to give before 3 hours, because sublingually it is the fastest route. 2 to 3 hours will be suffice. And laminary end, it is not used nowadays. So coming to the pain management before the aspiration procedure, what is that? Because we have to reduce pain and anxiety, because we have to give quality abortion care. For that, decreased pain is very important. So 2 components of pain management, one is non-pharmacological, one is pharmacological. What is the non-pharmacological? That is only counseling and psychological support. We have to tell the patient that there will be little pain in advance, so that they will accept that yes, there will be little pain. So we have to encourage the woman to relax and breathe deeply and perform the procedure gently and smoothly. Don't use don't dilate or use any instrument very forcefully. That will cause severe pain. That you have to look for. Coming to the pharmacological pain, that is the anxiety. 3 types of pain they have described. Anxiety, so pain during the cervical dilatation, and pain during uterine cramping during the suction. So for anxiety, we have to give anxiolytic, or we can give general anesthesia. If patient is very pain threshold is very less, very uncooperative, we can give general anesthesia. But everywhere it is not available, we can give diazepam and the anxiolytic. We can give it orally, 10 milligram tablet 1 hour prior to the procedure, or you can give slow IV. For slow IV, we have to be very careful, because sometimes it may cause some complications. So ideally, we will give diazepam 1 hour before the procedure. During the cervical dilatation, we can give local anesthesia, that is the pudendal block with 10 ml of lignocaine, we can do that. Or we can give ibuprofen also, that will also decrease the pain. During the uterine cramping, because during the suction and along with the suction that also causes some curate, that will cause severe uterine pain, that can be reduced by giving ibuprofen or a 400 to 800 milligram 1 hour prior to the procedure. But the disadvantage is it may cause the gastritis. So this is the steps of the MBA. Close the valve button, create a vacuum, ensure pain control medication is given at the appropriate time, ask the woman to empty the bladder. This is very important. Ask the woman to empty the bladder so that it will be easy procedure. Otherwise, there will be difficulty. Then use the antiseptic lotion. If you want, you can give the pudendal block with the lignocaine. Dilate the cervix by giving misoprostol previously and making it right, and insert the cannula gently. Then after you reach the, because before doing this procedure, you must have assessed the size of the uterus. So when you put the cannula inside, just go till the fundus. After reaching the fundus, withdraw the cannula 1 to 2 centimeters away from the fundus. Because if you, while moving up and down, you may cause perforation. So reach the fundus and come down a little bit below. And then rotate the cannula in 10 to 12 o'clock position with smooth, gentle motion. So how do you know that you have completely evacuated? So what are the signs of uterus is empty? This is all only recapitulation. We all know these things. This is only recapitulation. So if there are air bubbles or red or pink foam without tissue passing to the cannula, gritty sensation over the surface of the uterus, there will be gritty sensation like your coconut coring. And now if it is complete, the cervix will grip the cannula. Cervical gripping of the cannula by the cervix, and the uterus will contract and the size will decrease. From this we can know that yes, we have completely evacuated the uterus. And also after evacuation, we should always inspect the tissue. That is also very important, because instances are there, they have conducted the aspiration or evacuation, but later on the patient may come with ectopic pregnancy. Recently, we have just a similar case. It was a ectopic pregnancy in a cornu. So always see that the product has come out. This is very, very important. And after the procedure, we can advise for sterilization, or we can also give IUCD insertion. And after that, we have to wash the instrument and sterile it with 0.5% hypochlorite solution. Post-procedure care, monitor her for any complication and provide management as needed. She may leave the facility when it's stable and meets the criteria for discharge. And document all outcomes of treatment. Documentation is very important. Maintain the register. After care, management of abortion care, it may become an incomplete abortion, or infection may persist. There may be bleeding or ongoing pregnancy. These are the complications which may happen, and we should always look for this in the follow-up. And we have to educate the patient about the signs and symptoms of incomplete abortion, infection, and those things, and provide contraception. As per the guidelines, the new recommendation is, if you have done the quality abortion care, you have provided quality abortion care, there is no routine follow-up is required. In summary, coming to the conclusion, India has made a historic progress with this MTP Amendment Act of 2021 by increasing the gestational age to 24 and unlimited in other cases, and also improving the access to the safe abortion. Not much has changed in the technology update in the last decade. As providers, it is up to us to ensure safety and quality. Quality is also very important, and safety and quality both are equally important. Along with that, we have to provide respectful abortion services so that they will not afraid, they will not feel shy to come to us for the safety. Because we know if it is being done in quacks or unskillful person, there are lots of complications. So to avoid this, we have to provide respectful abortion services. Every client, it is an opportunity for us to inform her, to educate her, and to give proper information on contraception and counseling. That is very, very important. So So in India, abortion is legal. Let us make it safe and respectful. Samarth Bharat, Sampurna Bharat. So this is on conclusion. We all should join hands to provide respectful abortion care and make the abortion procedure safe and uncomplicated, so that the woman will come to us. This is also a part of woman empowerment. Thank you. Long live Foxy.
Thank you, ma'am. That was an excellent presentation, ma'am.
Thank you.
This is Dr. Prema Priya. I am OJ Associate Professor in Department of Obstetrics Gynecology in Vinayaga Missions in Tamil Nadu. So the next module is SAVER module. That is Safe Abortion Values, Evidence, and Rights or Respect towards Respectful Abortion Care. So, sir, first we'll see the videos, sir. So let us see what are the norms and stigma that is pertinent towards abortion, and what is the WHO guide to avoid those stigma.
Prema Priya, just half a second, please. Sorry, I just missed it. Shashmita, thank you very much. You've done a fantastic job. You know, you brought in your personal flavor also into all of this. Thank you so much. From the various names that I see here, I'm unable to identify any presidents and secretaries who have joined in. I do know Surekha is here. Any society presidents and secretaries have joined in? Please, can you identify yourself?
Sir.
Yes.
Swarupa, I can see you. Okay.
Yes.
Hi, Swarupa. Yeah.
I'm
Dr. Mohan Jandavarkar, President of Thane Obstetric Society.
Oh, welcome, Mohan. Yeah.
Sir, I'm secretary from Sitamarhi Obstetric Society.
Oh, very good. Good to see you, Lata, from Sitamarhi all the way. Huh? Okay. Anybody else is here?
Yeah, Dr.
Monica.
Yeah, Monica, I know
Monica
you.
from Alvar.
Yes.
Alvar.
Yeah. Hi. And who else?
Dr. Samatha from Mancherial, sir. She's our president.
Oh, okay. Very good. Good to see you from Mancherial Society as well. So welcome all of you, as well. While I have welcomed each one of you earlier, but thank you so much as a society for coming in and joining this important program. And I'm really looking forward to, some more participation from your respective societies in the upcoming programs. In case your members have missed it, please do go ahead and share all these information with everyone. And anything that you would like to say in a few words to your society members, please feel free to do so now before we get on to the third session.
What, sir, I want to make a comment.
Yes.
When we go for the MTP after 12 weeks, because now the only single medical practitioner opinion is required for after 12 to 20 weeks. And most of the MTPs are done for the contraceptive failure. So the question arises, what the woman was doing for last 2 months? She knew that she had a contraceptive failure 2.5 months before. Only then she can get pregnant. And when after 14 weeks or 16 weeks, which is a time for sex determination, she finds out that there is something wrong, and then she comes, I want an MTP for contraceptive failure. What is your advice on this topic?
I mean, Shashmita, would you like to comment here something before I say something? Or Uma or Prema, would you like to say something? You have to unmute, Shashmita.
It always happens. I'm Dr. Swarupa, Secretary of Mancherial. Most of the times, women are like that only.
Are you sure that she went for sex determination?
Ma'am, it's likely, because sex determination is very common. It is going on. It's not common, but it is still going on in the society.
No. And it is going on in broad daylight. No argument. no debate over that. It's going on. But unless we are very sure that she went for sex determination and it's a female, or whatever, sex determination and she's going for termination, we can't refuse termination of pregnancy. If she says failed contraception, we have to accept it.
Madam, but for the sex determination, it is imprisonment of the life. The punishment is when it is you are doing it for the sex determination, and even you don't know what she has undergone, because for what she was waiting for at least 3 months, because she's already 12-week plus pregnancy.
Yes, Mohan, you would like to add something?
It's a very simple thing. On one side, we are trying to give safe abortions. You have to trust the woman. It doesn't matter. If you know that she's done a sex determination, you don't do it. But if you don't know it and she says it's failure, you just take it as with a barrel of salt and finish it. Forget about one of the things that Dr. Sasmita said, but don't be judgmental and don't be biased.
Yeah.
Yeah, I think this is a very interesting question that you brought about.
Mr. Ajay, it's a very simple thing that you have to reach out to the people, don't antagonize them, don't trouble them, just accept them as they are. If they say it's a failure of contraception, it is a failure of contraception. End of story.
Sir, I agree with you, sir. Actually, the aim of this respectful abortion care is the same. So we should not force a woman that she should continue the pregnancy, and we should not judge her. If she requests for abortion and it is not for sex determination, then we should provide the services. If it is confirmed.
Mr. Ajay, can I add one more word here?
Yes, sir. One more point is.
1 minute. Let Mohan, Swarupa, let Mohan say it.
Yes,
this is something that my professor had taught me. That you go by the acid test. If this was your relative, what would you do? If this was your relative, what would you do? You do it. So I think we should just keep it. If the law says failure of contraception is acceptable, just accept it with a barrel of salt. Forget about it.
Yes,
but I have one thing. Sir, the thing is, recently, once we are filling our form Fs, and it says the woman had a previous female child coming for a termination, whether you determine or don't determine, you are in the suspicion, you are suspected. Yeah. And the thing is, nowadays in our place, we are getting calls from the DMHO office saying that your gynecologist has helped you in knowing the gender. And once our patient denies, no, she didn't, still they are insisting her to accept that, no, we came to know that your gynecologist has helped you. With almost all the gynecologists, they are getting these calls. Maybe they are doing a sting operation, we don't know, whatever it is. But provided the woman had previous girl child coming for termination after 12 weeks, in a case of claiming it to be a contraceptive failure or whatever it is, I think our gynecologists should be careful. And sir, as you're saying, take it as your relative and do it. Even if it is our relative, we don't stake our degrees
don't do that.
For anything.
No way.
Don't do that. That is what I'm saying.
No,
that's what I do.
Please be careful. Once it is a previous girl child coming for 12 weeks, after 12 weeks termination, please, it is very important you be cautious. Thank you, sir. That is what.
Okay. That's what I am doing. I don't do MTP after 12 weeks for contraceptive failure indication. It may be some other indication. I will do it.
Okay. So to be fair, with all these comments that have come in, it was a wonderful question and it did generate a lot of discussion. This is the kind of quality of discussion that we are hoping that we will continue going forward. And just basically to summarize, what is happening is we do not have any kind of control. We cannot step into the minds of the woman and understand what is happening and what is not happening. We just need to put 2 and 2 together. Where we feel there is a doubt, where we feel there is, some kind of question mark, we need to proceed with caution. We need to take all the precaution because we need to protect ourselves with the kind of situation that each of us are facing in the field with, doctors being beaten up, doctors being, taken up for different kind of issues. So we need to protect ourselves at every given point in time. And at the same time, wherever possible, 99% of the cases, we need to provide these services, which has to be respectful for the women of our country at the end of the day. On that note, can we move on to
one more, and then maybe, sir, it is a very important thing.
Okay.
See, up to 24 weeks, any termination indicated, whether it is a malformation or a social cause, we are doing it. Yeah, the other day we had one patient of 26 weeks claiming that she lost her husband in the last a couple of weeks ago. So what do we do after 28 weeks? She is at now 28 weeks. Being a widow, she's asking for MTP.
No, you can do. Legally, it's not possible to do.
But how can we help the patient in case we have to do? How, like, we had this bench or something like that, the medical legal bench.
She should
Do
have
we
We
have
have to
any?
file an application to the bench. Every
Yes.
district has a district committee. You should write an application. Hello, I am Dr. Surekha Taide. I am president of Devali Savangi OBGYN Society. And I would like to, according to the newer recommendations, the new MTP Act, you have to file such kind of cases to put them in front of the board. Every district will have a committee. Let them decide, okay? And they will tell us, they will guide us what to do in such cases. Our job is to help the patient file the application to the district committee. That is our job. After that, within 3 days of their judgment, we need to, whatever they suggest, if they suggest termination, we should do that.
Yeah. So thank you, Surekha. I did call out your name earlier, Surekha. I think you were missing in action. So thank you.
I'm so sorry.
Okay. On that note,
I just want to comment one thing.
Yeah.
We have to save ourselves first. Then we have to help the patient, because I have faced so many of the legal complications. They come for the MTP and they against you ki hai na, something happened and you did the MTP. There's so much of the legal complication. They are having the divorce cases also, and they all the time they involve the doctor. So you have to complete your records. You have to complete all your history, your everything, and you have to first protect yourself and then think about the patient.
Okay, great. I fully agree with each one of you. Prema Priya, you're on. Sorry to keep waiting. Yeah.
Yes, sir. So with the wonderful discussions, let's move on to the videos of WHO guide to avoid the stigma towards providing abortion. So what are the norms and what are the stigmas that is pertaining towards abortion, and how to avoid the stigma? So coming to this module aims to define respectful abortion care. According to WHO, highlights how norms and stigma affect services and provide WHO safer resources for respectful abortion care. Next. So what is respectful abortion care? It is adopted from the respectful maternity care recommended by the WHO. It refers to the care that maintains safety, dignity, confidentiality, ensures freedom from harm and mistreatment, and enables informed choice and continuous support during and after all types of abortion. Next. In simpler terms, respectful care means you as a provider or as a patient treat and are treated with dignity, empathy, and compassion, regardless of your race, ethnicity, gender, socioeconomic status, or reproductive history, such as previous pregnancies, miscarriages, or abortions. If you ever feel that something isn't right, then speak up. As a health professional, it is our duty to listen and support. Always remember that communication is the key. Next. So what are the norms and stigma? Next. So let's watch the video.
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors, like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and/or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others, personally and professionally.
So coming to the stigma and norms perpetuate disrespect and abuse. Coming to the categories of disrespect and abuse, it includes physical abuse such as slapping or intimidating physically, verbal abuse such as non-consented care, shouting or screaming, sexual abuse such as abuse of power, taking advantage, stigma and discrimination, which we could see in the Saber videos, and failure to meet professional standards of care, poor rapport between the woman and the providers, and health system constraints. What are the rights of every woman? Every woman has a right to be freedom from harm and ill treatment. Right to information, protection under laws such as MTP and POXCO. Informed consent and refusal and respect for their choices and preferences and to provide dignity and quality of care. Right to timely health care and to the highest attainable level of health, liberty, autonomy, self-determination and freedom from coercion. Next. So coming to the domains of respectful abortion, there are 12 domains, which includes being free from harm and mistreatment, maintaining privacy and confidentiality, preserving women's dignity, respecting women's choices, engaging with effective communication, providing information and seeking informed consent, ensuring continuous access to support, enhancing quality of physical environment and resources, providing equitable abortion care, availability of competent and motivated providers, provision of contraceptive advice and commodity security, and continuity of care and counseling. Next. So coming to the WHO Saver Toolkit, which includes safe abortion values, evidence, and rights. Video, please.
No woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO Saver, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone, to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO Saver Toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. Saver has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. Saver is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
Coming to the guide to avoid stigmatizing language. Here also on video is there.
How to talk about abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or Registered Medical Practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not consensuous individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix side denotes killing, which is not appropriate when describing abortion. When referring to sex selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision, and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome, which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro-life implies that those who support legal abortion access are anti-life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights-based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business-related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework but may be safe if performed by a trained provider or When a person has access to high quality medication, information, and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the 3 P's provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex selective abortion is illegal. Provider and place need to be safe, trained, and certified.
Yes, so I want to emphasize that the provider, place, and the process should be safe in providing the abortion. So the momentum has been created and the laws has been changed. The FOXI, the largest provider base for abortion care. Because of the COVID times, we came to know that the online training is possible and the respectful abortion care can reach all providers. Medical methods of abortion uptake has increased, and this provides early, safe abortion and ensures no PCP-NDT conflation. Patient safety, respect, and quality matters more than ever, and we all have a role to play. Next. So it's time to strengthen the implementation. So one RMP opinion is needed for providing abortion services up to 20 weeks of gestation. From 20 to 24 weeks of gestation, 2 RMP opinion is needed. And more than 24 weeks, we should refer to the medical board. One provider has more responsibilities, including the counseling, contraception, referral, and compassionate care. The eligibility has been expanded up to 20 weeks. The eligibility is for all women. And from 20 to 24 weeks, it is mainly for the special categories of the vulnerable women, involving the rape and less than 18 years. For birth defects, there is no gestation limit and the service should be provided. For 20 to 24 weeks, for special cases, need sensitivity and judgment-free and provide timely services. This also emphasizes on the prioritizing the confidentiality and safety. So the name, individual details should be kept confidential and should not be revealed to anyone except the person authorized by law. The ground of failure of contraception has been extended not only to the woman but also to her partner. So overall, we should aim to provide respectful, quality, and dignity service in providing abortion services. So thank you all. Next slide. So coming to the recap questions. Next. So next slide. So there are some few recap questions. So according to WHO, restricting access reduces the number of unsafe abortion. Is it true or false? Please leave your comments in the chat box. So according to WHO, restricting access reduces the number of unsafe abortions. Next. The answer is false. So restricting access does not reduce the number of unsafe abortion. Next slide. The MTP Amendment 2021 requires a minor less than 18 years to obtain written consent from parents or guardians before she can undergo a termination of pregnancy. True or false? Next slide. So it should be reported to POXCO. Next slide. 30-year-old woman recently widowed wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. Yes or no? Please leave your comments in the chat box. So the answer is no. Next slide. No. Next slide. So in India, abortion is legal, and let us all join hands and make it safe and respectful. Next slide. So I would like to remind you that at the end of the session, there'll be post-its and feedback. Please fill those to get your certificates. Thank you all.
Thank you so much, Prema.
Thank you, sir.
Presentation, yeah. And good to see the enthusiastic way in which you're presenting this every time in so many of the forums, yeah. Huge, big thank you to you, brother.
Thank you, sir. Thank you so much.
We move on to the last presentation for the day, please. Thank you.
So can I share my slides?
Yes, madam. Yes, ma'am.
Yeah. Can you see?
Yes, madam, but not full screen.
Amazing. But now I'm sharing from the laptop. It's full screen here on my laptop. Can you share? Otherwise, Shriman?
Yes, ma'am, I'll do.
Can you see now? It's full screen.
My screen
Is it shown as full screen?
Madam, I share my screen, madam. It is visible.
Okay. And now, moving on to our last module of this RAC training program. After 1.5 hour of this program, it would be certainly a difficult task to talk about, pre and post abortion care counseling and how to use technology to adapt to the current and changing trends towards online consultation. Next. So first, how do you define counseling? Counseling is defined as a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. Now, during the whole process of judgmental counseling, please never be judgmental towards whatever patient is discussing. Important point to consider here is that patient is voluntarily seeking help, and so she or he will be open for discussion to share thoughts and feelings, and we should never be judgmental. Next slide. So what is pre and post abortion counseling? We should note that pre and post abortion counseling is integral part of comprehensive abortion care services and is as important as the procedure itself. This counseling should be focused towards helping women take decision about a family planning method or her future reproductive views. If needed, but not a must, a partner should be involved in counseling to maintain synergy and move on. Next. Pre-procedural counseling should help women decide about termination of pregnancy. Help women to choose method of termination of pregnancy once decided about termination of pregnancy. Give her what are the various methods available, medical, surgical, and ensure that she understands whatever you have discussed about either methods, may it be medical or surgical. And let her choose her method of choice. Ensure delivery of complete information about the whole procedure till completion, and help women to adopt a contraceptive method. Next. This pre-procedure or pre-abortion counseling is to, I mean, it should happen in a place where there is privacy, and you have to ensure that there is confidentiality. Be non-judgmental and sensitive to whatever the couple or patient is discussing. We as a doctor should never be judgmental. And where once you try to become judgmental, patient might lose confidence in you. And so please, can't be judgmental about this. Don't use any medical jargon during your counseling session. Do your counseling in simple, plain language. Give her time to allow, for any questions, clarify her doubts in the form of open discussion. And that's actually what is defined as counseling. And lastly, once decided on termination of pregnancy, on the method of termination of pregnancy, assess her for the whole procedure, how suitable he is and how safe it is to do on that particular patient. Next, other issues you need to discuss during peri-abortion period is about the family planning services. Next, please. You have to inform her that there will be a quick return of fertility once a termination of pregnancy is done. And so you have to seek this opportunity, during this pre-abortion counseling for contraceptive acceptance. And it's suggest a minimum of 6 months gap before her next pregnancy by counseling about health benefits and better future pregnancy outcome. This is for us to note that 90% of abortion-related maternal mortality can be prevented by ensuring contraception. So that's the reason why it is so important to discuss about family planning procedure during pre-abortion counseling session. Next. So, when do we start the family planning counseling? We can start at a first visit unless there is some amount of grief involved. When there is an amount of grief involved, you can take an opportunity during the process of abortion or post-abortion. So what do you counsel during the pre-abortion family planning counseling session? You should tell them there is a quick return of fertility, maybe as early as 10 days or up to 4 weeks. Discuss the various family planning methods available in our basket. Help her choose the family planning method of her choice. And once she chooses the method, give her some method specific counseling or information, and also do advise a woman about the high risk behavior whenever applicable, and about the risk of sexually transmitted diseases or HIV. If the woman is not willing for any contraceptive method, you shouldn't refuse MTP. Try and counsel her after the procedure again if there was an initial refusal. Next slide. So what are the general guiding rules for suitability of post-abortion, assessing suitability for post-abortion contraception? So before you jump on giving her some contraceptive method, you have to check if the abortion process is complete and there is no evidence of sepsis excuse me, or no retail products of conception. In case there is a delay after the previous termination of pregnancy, please ensure that there is no fresh pregnancy. Next slide, please. Coming to the post-procedure counseling, ensure woman has understood all the precautions and necessary care she needs to take following the post-abortion period. During this period, we should again take an opportunity to counsel for contraception in case she hasn't accepted any previously. Reinforce the need for continuing the use of contraceptive method, whatever she chose. Next slide, please. So during the post-abortion contraceptive counseling, it's the same procedure as in the pre-abortion care. Continue to ensure privacy and confidentiality. Reassure her in case she has any questions or problems post-abortion. And repeat the information about post-procedure care and danger signs and when she needs to report and how to access you after post-abortion if she has any issues. Next slide. Coming to the post-abortion family planning counseling, if a woman has already opted or chose her contraceptive method, appreciate the choice she made. And some contraceptive methods can be adapted immediately, say like IUCD or medroxyprogesterone acetate injection, or even the oral pills. And whatever method she chooses, give her a follow protocol as to how she has to follow with you, how regularly she has to take her pills, or how frequently she needs to take an injection, and also discuss about her future reproductive plans, so that you can suggest her on when to discontinue the contraception or whatever. If she has any queries, you address all her questions and also provide information leaflets of any particular contraceptive method you have. If she has been undecided about the contraceptive method or about the whole contraception process, first allay her anxiety. It's important to explain her that it is important for immediate adaptation of contraceptive method, or otherwise she might become pregnant immediately in the next cycle itself. And then, whenever necessary, involve the couple. And if nothing has been chosen, do discuss with them about emergency contraceptive pills if whenever needed. Next, please. Post-abortion contraceptive methods. So we'll just go through briefly through various methods currently available and when it can be started after first and second trimester terminations of pregnancy, and if needed, any additional information that should be provided for the couple. Now, talking about the barrier methods, a commonly used barrier method is a condom, and it can be used as soon as the sexual activity is resumed after first and second trimester termination of pregnancy. It has no hormonal side effects, can be used without consulting a healthcare provider, easily available, and also it has an additional protective action against sexually transmitted infections, including HIV. And this is the only contraceptive methods which enable men to take responsibility of contraception. Next. Now coming to the next method of contraceptive choice, which we will discuss, is the intrauterine contraceptive device. Whatever is the contraceptive device made with 380A or 375 or 280, whatever, after first trimester termination of pregnancy, a copper T can be inserted immediately or up to 12 days after confirmation of completed abortion using the surgical method. With medical method, it can be inserted around day 15 of the process, provided complete expulsion of products of conception is confirmed and risk of any infection is ruled out. After second trimester termination of pregnancy, it can be inserted immediately or up to 12 days after the procedure is complete, and contraindications like any infection or retained products of conception are ruled out. Now we know that it's highly effective. It can be used for up to 5 years or 10 years or 3 years, whatever the device we have inserted. Do explain her, what kind of device you have inserted and for how long it's likely to be effective. And it can be provided by trained doctors, or even ANMs and nurses can be easily trained so that they can be insert the IUCDs. No interference with sexual activity, and there will be immediate return of fertility upon removal of the device once. Please, next slide. Coming to the hormonal contraceptives, combined oral contraceptive pills can be started immediately or up to 7 days after abortion using surgical method. With medical method, it can be started on day 3 along with the dose of misoprostol, or within day 15 of the process after completion of after confirmation of a completed abortion. Post second trimester termination of pregnancy, combined oral contraceptive pills can be started immediately or up to 7 days after abortion. And then what additional information you can provide is that there are certain non-contraceptive benefits of oral contraceptive pills. Particularly important are that they regulate the menstrual cycle, can be provided by all healthcare workers after first screening by a trained provider, no interference with sexual activity, offer protection against ectopic pregnancy, endometrial and ovarian carcinoma, benign diseases such as the fibrocystic disease of the breast and fibroadenomatosis. And one point you have to note is that it's not suitable for women who are breastfeeding their babies, and the babies are less than 6 months old. It's definitely shown to interfere with the milk production, and so it's not recommended for women who are breastfeeding and less than 6 months old. Next slide, please. The next hormonal contraception we will discuss is about the DMP, or the medroxyprogesterone acetate long-term injectable. After first trimester termination of pregnancy, it can be inserted immediately or up to 7 days after surgical method. With medical method, it can be started on day 3 with the dose of misoprostol. Post second trimester termination of pregnancy, it can be started immediately or injected immediately or up to 7 days after abortion. The additional information you can provide with this particular contraceptive method is that it's highly effective, no additional interference with sexual activity, no effect on quality and quantity of breast milk unlike combined oral contraceptive pills, definitely no estrogenic side effects, and offers some protection against ectopic. But then, you have to tell them there might be a slight delay in return of fertility after a usage of 1 year. Next slide, please. Then coming to the permanent methods of contraception, you have to stress upon that these are really permanent method of contraceptions, and that permanent methods of contraception, and you can't take it back once done. So female sterilization can be performed after an abortion in the absence of any infection or severe blood loss concurrently or up to 7 days, both by mini-lap or laparoscopic sterilization. With medical method, it can be done only after the first menstrual cycle. Post second trimester termination of pregnancy, mini-lap sterilization can be performed concurrently or up to 7 days after an abortion in the absence of any infection or severe blood loss. Laparoscopic sterilization is not recommended in this situation. Again, I'm insisting that you have to counsel them that it is a permanent method of contraception, highly effective. Effect starts immediately. No interference with sexual activity, no hormonal or long-term side effects, no effect on breastfeeding, and also offers protection against ovarian cancer. Vasectomy is a surgery performed on males independent of the timing of any procedure or any, procedure in the sense termination of pregnancy. So men can go independently of the termination of pregnancy on his wife. Now this vasectomy again is a permanent method of contraception. No interference with sexual activity, very effective, but you have to educate them. They have to use additional method of contraception for few months post vasectomy till they are sure that the sperm count is 0. Next slide, please. So just this will be a quick recap. Next slide. Recap of what we have discussed in the last 4 to 5 slides as to when we can start each method of contraception. Please, next slide. Next slide. And so this brings us to discuss about the future of SRH services. How can we utilize technology, by offering video consultations or teleconsultations in sexual and reproductive healthcare services. Next slide. COVID has taught us all these as how to use teleconsultation or telecounseling or teleguidance or reference, and how to provide information by just forwarding information leaflet or some links to websites or whatever. Next slide. Now everybody, I'm sure, is well versed with the websites, get information from the internet, and also they are very, most of the couple patients are very smart and they know how to use social media more than us. So, and also now there are lots of helplines available which provide patient education, leaflets on the website for free access. WHO, Ministry of Health and Family Welfare, RCOG, ACOG, most of them give patient information leaflets and are readily accessible by most of the patients. So how can we, use these teleservices or technology to improve sexual and reproductive healthcare services in our country, or maybe utilize it for medical terminations of pregnancy also? So next, please next slide. So, we all learned, patients have learned how to use teleconsultations or teleservices. It's very simple, approachable, and we are sure that there is some amount of confidence patients gain if they have any small doubts over, how the procedure or any post-procedure complications. So it can be a way to maintain ongoing communication with us, with the provider, and it's easily accessible. And even if the patient is far and can't travel, she can easily communicate in the form of a teleconsultation. And definitely, the accessibility has improved with this. The major weakness is, as we are missing, our conferences, the major weakness is that they lack face-to-face communication, and so probably sometimes when you have to demonstrate few things, say like how to use a oral contraceptive pill, or how to you want to demonstrate on how to use a female condom or whatever, then might be difficult to do everything on a teleconsultation service. So there will be an ample opportunity for the opportunity of access to sexual and reproductive healthcare services increases with teleconsultation. It definitely will ensure privacy and comfort because they talk from their home in their private area, and definitely improves the cost, it reduces the cost the patient has to bear, the logistics, the travel expenses, the stay, whatever, and also definitely cut down on the number of visits to the hospital. The major threat is that everything might not be possible on teleconsultation. You might miss certain diagnoses, or maybe you can even misdiagnose the condition whenever it's entirely provided on a teleconsultation, when the service, treatment or the assessment is entirely done on a teleconsultation. Next, please. So how actually can we, can we mix and do it in the form of a hybrid thing? And how actually you can apply for sexual and reproductive health or for MTP. Maybe a patient will be coming to for the initial assessment, confirm the diagnosis, confirm it's an intrauterine pregnancy, discuss about post-abortion contraception methods and the need for contraception. And whenever needed beyond these, she can go for a teleconsultation or a video conference or whatever, and she can come upon a follow-up once if needed to get a further contraceptive method or a IUCD inserted or whatever. So the number of visits can be cut down from 4 visits to maybe 2 visits or 1 visit, depending upon the individual situation. So kind of hybrid service can be adapted for medical management of termination of pregnancies. So next slide. The key messages here is that post-abortion family planning services is extremely important, and as important as the termination of pregnancy itself. And we should readily able to offer couple with all the various methods available, bring couple on board and strive for near 100% coverage of contraception. Capitalize on the basket of methods available and applicability in the post-abortion period, and also as far as possible use technology for comprehensive abortion care services. But the major concern is about the policy, about the malpractice issues that might crop up. But again, onus is on us on how ethical you would want to practice. Definitely, it improves access to comprehensive abortion care services, that as it reduces the cost and decreases the number of visits to the hospital, and it becomes accessible to remotest to the remote women. I mean, far from the hospital women in the sense. So regarding malpractice, again, there are certain policies laid by government about teleconsultation services. Do strictly adhere to those policies. And also adolescent reproductive health also can be done both by offline and online. Next, please. And so this brings us to the end of this, RAC training program for the day. Please do remember there are that in India abortion is legal. There are certain rules and regulations that we follow. Please do, offer contraceptive methods whenever the patient comes for termination of pregnancy. And there is a post-test questionnaire which you need to fill. to get your certificate. Any questions, please post on the chat box. Thank you.
Thank you so much, Uma. It was a marathon session for you while sitting in the hospital. You have not yet got home. Very persuasive, and thank you so much for the same. Shriman, can you go ahead and post the post test, please?
Yes, sir. Yes, sir.
So thank you each and every one of you for joining in today for this session. And Sashmita, you have quite a bit of stamina to be sitting through this entire thing yet again. Thank you so much, and please convey my huge regards to PC in Eton. And Surekha, I hope to see you sometime soon in one of the meetings. And if there's nothing else or any other question or any kind of input that you would like to give, great. And I would just invite any last minute comments from Mohan, Lata, Swarupa, or from Monica before we call this meeting to a close, please. And Surekha, of course, yeah.
Very interesting. And if it was marathon for Sashmita, it was marathon for us also.
Thank you, sir.
Swarupa, you would like to say something?
Thank you, sir. And I think we should give more emphasis on the contraceptive counseling so that we can reduce the MTP rate.
Yes, yes, that is very, very important. Contraception counseling should every antenatal visit also we should give contraception counseling.
Even in the labor room, we should do the contraceptive counseling because at that time the patient is very receptive to it.
Yes.
And men should be involved for contraception because female is a passive partner in our society. So we are not focusing on the contraception for men.
We have to empower also women to take the decision for herself. We have to empower them. That decision power should be there also.
But still, in our part of this part of India, the female cannot take much decision.
That is their truth. Just make it true.
Very nice.
But ma'am, time is changing.
Thank you so much, everyone. The post link has been given in the chat box. Just click on that link, and you will be taken to the next screen. And in case Mohan, Lata, or Swarupa, or Surekha, you would like to carry this on, some members who have missed it today. I have already posted for the 10th of June. Again, there is the same program with different speakers. Please alert everybody, and they could also join in. So the idea is that they should not miss out on important information.
Yes,
and my request to all of you, to Mohan and Lata and Swarupa and Surekha, is please. And I think Samta is also there, right? Yeah. Please do send in your society's bank account details so that in case you have already done it, it's fine. Do not resend it. In case you have not sent it, please send it so that I will have the honorarium processed and send it to your accounts immediately. Okay?
Okay. Okay.
Thank you so much.
Thank you.
Have a lovely evening, each one of you.
Okay.
Thank you, sir.
Bye, doctor. Thank you, sir. Bye.
पहले ये बनाया क्या था मेरा इससे भरवा लो इसके पास जाके